From the JAMA Network, this is the JAMA Medical News Podcast, discussing timely topics in clinical medicine, biomedical sciences, public health, and health policy, featured in the medical news section of JAMA.
Welcome to this news roundup. I'm Kate Schweitzer, Associate Managing Editor of JAMA Medical News. On today's episode, we're talking about 3 stories we published in the past weeks. The first is on the U.S. government's announcement of a joint nutrition regulatory science program, and what experts say will be essential for its success. Then we'll discuss the first blood test to be reviewed and cleared by the Food and Drug Administration for Alzheimer biomarkers. Finally, we'll explore a growing movement that aims to care for caregivers, particularly those who support a burgeoning population of older adults. Lead senior staff writer Rita Rubin is joining me today. Hi, Rita.
Hey, Kate.
And we're joined for the first time by Virginia Hunt, who is most recently our Northwestern Medill Journalism Residency intern. Welcome, Virginia.
Thank you, Kate.
Let's start with our coverage of the joint NIH and FDA announcement about the creation of a new federal program that would bridge nutrition research with regulatory policy. In reporting this news, I kept being reminded of an FDA initiative from 30 years ago that centered on the same goal. But then it wasn't about our food and the obesity epidemic. It was about smoking. The FDA was determined to dismantle what was at the time the leading cause of preventable death in the U.S. With the support of the FDA, researchers were then able to uncover what tobacco companies were doing behind closed and locked doors, and then designed a regulatory system to interfere with it. As a result, the smoking rate among young people dropped dramatically, from its mid-90s peak of 36% to just under 4% in 2021. It was a successful blueprint that is being revived for this new collaboration targeting the, quote, diet-related chronic disease crisis brought on by, in no small part, ultra-processed foods. Much like how Americans deserved to know how cigarettes were being made to be so addictive, a U.S. Department of Health and Human Services spokesperson told me that Americans deserve to understand how the foods they eat affect their health, that it's time we take those learnings and apply them to nutrition. None of the sources I interviewed could argue with the need for a nutrition regulatory science program. Research has shown that diets high in ultra-processed foods are associated with a range of adverse health outcomes, from obesity to type 2 diabetes to cardiovascular disease to even depression. Still, the shared concern is that there's no way currently to execute such a program. The one-page press release was short on details, much like the recent HHS press conference about eliminating synthetic food dyes, which we covered recently. The sentiment that this is a good idea in theory, but won't amount to much in practice, has certainly been exacerbated by the ongoing ramifications of the personnel cuts within the National Institutes of Health earlier this year. But it also stems from the very nature of nutrition research being, frankly, a low priority. Over this decade, it's represented less than 5% of the total funding allocated by the NIH annually. The Office of Nutrition Research has consistently managed a budget of roughly $2.2 million. By comparison, the Tobacco Regulatory Science Program I mentioned earlier began with $53 million in funds. So not only is funding a concern, but nutrition research is also just notoriously challenging. Most existing studies are observational in nature. To establish true causality, long-term randomized controlled trials are necessary, but those are prohibitively expensive and extremely difficult to conduct, considering they require participants to remain under strict observation for weeks at a time. Several sources I spoke to pointed to the recent work led by Kevin Hall in his well-known trial involving 20 adults who were housed at the NIH Clinical Center for 4 weeks. It took a lot of effort, but it demonstrated for the first time that ultra-processed foods caused people to overeat. But this research has stalled after Hall announced his early retirement from the NIH, citing censorship of his findings by federal officials. So, unfortunately, this is the type of research that could answer some of the very basic questions around ultra-processed foods. After all, the general public may know on some level that sugary breakfast cereals and potato chips and ready-made meals aren't good for them, but A, ultra-processed foods still account for 60% of the daily calories consumed in the U.S., and B, scientists still don't know what it is about them that actually makes people sick. Is it because they have additives and preservatives? Is it because they're high in sodium or unhealthy fat or sugar? Or is it because they're ground to a pulp and easier to digest and thus don't make you feel full? If we want to regulate ultra-processed foods, we need those answers. And just asking people about their consumption of, say, bacon will not be enough. We need information about the specific brand of bacon and its specific processing method and its specific nutrient count, for starters.
Yeah, Kate, this seems to be where regulation needs to step in, right? What are the challenges there?
Right. With tobacco, we had federal agencies launching investigations and handing out subpoenas. There were industry insiders and whistleblowers, but not so with nutrition. To date, federal food law is limited to acute illness, prohibiting foods contaminated with toxic chemicals or bacteria like salmonella. Those types of food poisoning or foodborne illness scenarios amount to about 3,000 deaths in the U.S. each year. But if you look at deaths that resulted from unhealthful diets, that's closer to 354,000 deaths per year. Nearly 1,000 people every day die from nutrition and obesity-related chronic illnesses. And again, there's been no regulation in large part because there's no clear paper trail back to the specific food manufacturer. There's no way for consumers to be able to tell what a specific food is doing to their health within a day, a week, or even a year. Ultra-processed foods can make you feel sick fast, but not so quickly that you notice it. It's like the perfect crime. And it's why the food industry has no incentive to invest in the science to make safe products. Ultra-processed foods are some of their most profitable, and they consider the ability to market to children essential to many of their business models. So could they voluntarily make and market healthier products? Sure, but experience tells us they won't unless they're forced.
So, if they could pull off this type of program, what would the results be? What could we expect to see come of it?
So the ultimate goal would be for sound research to lead regulation. At its simplest, that might take the shape of front-of-package warning labels, much like those used in Latin American countries like Chile. They feature black stop sign-shaped figures indicating if a product has excessive sugar, sodium, or saturated fats. If we're thinking bigger, one expert I spoke to who served at both the FDA and the U.S. Department of Agriculture believes the FDA could cut the childhood obesity rate in half within a decade if it used its regulatory tools in partnership with the USDA. See, the USDA sets the overall nutritional standards for school meals and administers SNAP, or the Supplemental Nutrition Assistance Program known as food stamps. And this expert pointed to Walmart as a perfect example. It evolved its business in the late 80s to include grocery offerings, in part so it could accept SNAP benefits. So there's certainly an option where regulatory agencies could say, look, if you want to sell your foods in these programs, you'll need to adjust your formulations. And it's something some states have already begun. Indiana, Iowa, Nebraska, for instance, they restrict soda and candy from SNAP purchases. Of course, on the other side of this coin, public health experts do worry that taking away resources from food-insecure families could worsen stigmas and hurt more than it helps, especially if we institute bans without the evidence to back them up. After all, we're still paying the price for the erroneous determination nearly 60 years ago by government agencies that total fats were the culprit. For decades that followed, low-fat diets were all the rage, according to everyone from the Surgeon General to the American Heart Association. That is, until research later demonstrated that it's the type of fats, not the total fats, that really matter. But by then the damage was done. To this day, many consumers still believe fat is inherently bad. All that to say, this is important work, it's complicated work, and it's going to take a combination of rigorous evidence-based research, strong regulatory power, and substantial funding. Estimates of at least $100 million over 5 years have been floated. But again, at this point, researchers, regulators, and food manufacturers alike are all still waiting to find out more about what's to come. All right. Next up, we'll talk about another FDA announcement. This time about its clearance of the blood biomarker test to be used in diagnosing Alzheimer's disease. Rita, it seems the new tests may be less invasive and increase accessibility. Based on your reporting, what can you tell us about the news?
Well, amyloid plaques in the brain are a hallmark of Alzheimer's disease, which is the main cause of dementia. But until fairly recently, the only way to determine whether they were present was on autopsy. Physicians had to diagnose Alzheimer's disease by ruling out other potential explanations for cognitive impairment. And even specialists sometimes got it wrong. In recent years, though, 2 tools have become available for determining whether amyloid plaque was present in the brains of patients living with cognitive impairment. And those tools are positron emission tomography, or PET scans, and lumbar punctures to collect small amounts of cerebrospinal fluid. But those methods are expensive and difficult for some patients to access. Plus, of course, a lumbar puncture is pretty invasive. Now, the advent of anti-amyloid monoclonal antibodies in the last few years made confirming the presence of amyloid plaques in the brain even more pressing. Clearly, it wouldn't make sense to prescribe an anti-amyloid therapy to a person with cognitive impairment who did not have any amyloid plaques in the brain to clear away. Now, a blood test would be a much simpler and likely less expensive way to check for brain amyloid. At least 3 companies, including the testing giants Quest Diagnostics and LabCorp, have been offering blood tests to assess the presence of amyloid in the brain. None of them have been reviewed by the U.S. Food and Drug Administration, but through what some call a legislative loophole, they're still allowed to market their tests as laboratory-developed tests. Well, the news here is that in May, a blood test to assess brain amyloid became the first to be reviewed and cleared by the FDA. Its maker, Fujiru Bio, told me it would be available in June. It's supposed to cost in the low 3 figures, and any CLIA-certified lab can perform it, making it more acceptable and accessible to patients than a PET scan or a lumbar puncture. Plus, because the FDA has cleared it, the test will become the first to be covered by Medicare, and private insurers are likely to follow Medicare's lead. But as one physician told me, the test's accessibility is a double-edged sword. It's useful for accurately diagnosing Alzheimer's disease in people with cognitive impairment who are 50 years of age or older, for whom the blood test is indicated. Now, even if they're not considering anti-amyloid therapy, which, a lot of people aren't interested in because it has to be infused every few weeks, and it also carries the risk of a rare but potentially fatal complication. But even so, some patients and their families still want to know if they definitely have Alzheimer's disease. Now, on the other hand, some dementia specialists worry that the ease of a blood test will lead to primary care physicians ordering it for the worried well. People who think that their inability to remember where they place their keys is an early sign of dementia. The problem is that amyloid accumulates over years, and autopsy studies have shown that about 30% of cognitively normal older individuals have amyloid in their brain. It's possible if those people had lived longer, they eventually would have developed dementia, but they died cognitively intact. And so we don't really know what to do with people if they do not have cognitive impairment but test positive for amyloid in the brain. At least right now, we don't know what to do. Meanwhile, dementia specialists are awaiting practice guidelines being developed by a committee convened by the Alzheimer's Association. The guidelines are expected to be presented in late July at the annual Alzheimer's Association International Conference.
So how does the FDA-cleared blood test present its results? Is it just, yes, you have brain amyloid, or no, you don't?
No, it's not a binary result. The test has 2 cut points, and patients who score above the upper cut point almost certainly have amyloid plaques in their brain. But those who score below the lower cut point almost certainly do not. Unfortunately, according to the manufacturer, about 1 in 5 people who take the test fall between the 2 cut points, so it can't be determined whether they have brain amyloid. So they fall in this gray area. To answer that question, they still have to go on to get a PET scan or a lumbar puncture.
And can a blood test replace a PET scan or a lumbar puncture?
We really don't know yet. as I said, the dementia specialists I spoke to are waiting for the Alzheimer's Association guidelines on blood biomarker tests. Meanwhile, they said, such tests are useful in triaging patients who are interested in anti-amyloid therapy. Only those who'd score above the upper cut point would be referred to get a PET scan or lumbar puncture. So blood tests could save some patients from having to undergo one of the less convenient tests. If the blood test shows that it's unlikely they have amyloid in their brain. But for patients who simply want confirmation that their cognitive impairment is due to Alzheimer's disease, dementia specialists told me that they think the blood tests alone would be sufficient.
Thank you, Rita. Our next story also centers around our aging population here in the U.S. But Virginia, you investigated an often overlooked group that is frequently associated with older adults, and that is the unpaid family caregiver. Please walk us through some of the new programs and federal actions aimed at supporting their efforts.
Yeah, thank you, Kate. So, people caring for a family member with special needs, such as a disabled child, a convalescing partner, or an aging parent, commonly feel alone, but they certainly aren't. Up until the COVID-19 pandemic, unpaid family caregivers made up nearly 1 in 5 U.S. adults, or about 53 million people, with estimates that this number has grown even more since. It definitely has for people who provide support to older adults, with this section of caregivers rising to 24.1 million in 2022, nearly a 33% increase since 2011. If you've heard the term sandwich generation being used more often to describe those currently between their 30s and 50s, these increasing numbers are likely why. Even though the term was invented in the 1980s to describe the phenomenon of raising children while also caring for one's aging parents, use of the phrase has increased since the baby boomer generation has begun to move into their late 60s through their early 80s, and thus also to need more support. The trend is not expected to slow down anytime soon either, as this proportion of the population is expected to encompass an additional 24 million people who may need caregiver support by mid-century. But our sources pointed to there now being a growing need to care for these caregivers, who currently face a slew of adverse physical and mental health outcomes, including obesity, arthritis, mental stress, and depression, all at higher rates than the rest of the population. And with some senior programs not still fully operational since closing during the pandemic, as well as some other changes to the landscape of caregiving, the hours they spend supporting older adults have also increased. This has led to more tasks falling onto caregivers with the provision of more complex care, such as operating catheters and oxygen machines. And feeling unprepared to perform these jobs can cause a lot of anxiety, one of our sources noted. But there are reasons to believe that things may be getting better. The Caring for Caregivers model, established by Rush University in 2019, has shown real promise in improving outcomes for both caregivers and their care recipients. Clinicians who observe a caregiver in need of support can refer them to the program, or these caregivers may seek it out themselves. From there, a clinical member of the C4C team conducts an evidence-based assessment that includes tests for anxiety, depression, caregiver burden, and health literacy, as well as social determinants of health screening. Then, a plan specific to what matters to the caregiver and their care recipient is created by the team. There has also been a great deal of federal support for caregivers in the past several years, including the recent reintroduction of the Credit for Caregiving Act, which would provide a $5,000 tax credit to support family caregivers, of whom nearly 1 in 3 report moderate to high financial strain from the role. This bill comes on the heels of a host of other legislative actions, including the delivery of the National Strategy to Support Family Caregivers to Congress in 2022. After that, in 2023, the first executive order related to caregiving directed the U.S. Secretary of Health and Human Services to ensure that hospitals actively involve family caregivers in the discharge planning process, and to consider a healthcare repayment model that would include family caregiver support such as respite care.
Yeah, I'm sure a lot of people can relate to the struggles that you mentioned. Can you talk a little bit more about the details of that Caring for Caregivers program at Rush?
Absolutely. So the C4C program, as they often abbreviate it, really focuses on the individual needs of the caregiver and care recipient pair. As I mentioned before, there's an initial screening call, and then the clinician and caregiver work together to create a personalized intervention plan, which may include conversations with a therapist, During skill-building meetings, which are another option for the pair, medical professionals identify goals for both the care recipient and their caregiver and work to increase the caregiver's confidence. Or the caregiver and the patient can opt for care team planning meetings to coordinate each person's role in tasks like doling out medication. But ultimately, the length of the entire process may last anywhere from a few weeks to half a year, because it really is tailored to each pair's needs. The model is strongly built upon what matters to the caregiver and the recipient. Therapists have the ability to tailor sessions based on spirituality, for example, or focus on reducing stressors, improving communication, or addressing unresolved family conflicts, depending on what is most important to the pair. This customization is hugely important because caregivers are far from a homogeneous group, and often caregivers who are also part of another minority group may face unequal challenges. For example, the economic load of caregiving for people with Alzheimer disease and related dementias is inequitable amongst different racial groups. Also, in some cultures, using the term burden to describe the stress that a caregiving role may cause can feel disrespectful or ultimately turn the caregiver away from seeking further support. The C4C program also aligns with the 4 M's of the Age-Friendly Health System, which is an initiative developed by the John A. Hartford Foundation that emphasizes what matters, medication, mentation, and mobility to create a comprehensive and equitable treatment plan. In C4C, the 4 M's are addressed for caregivers as well as care recipients, which is a first for caregiver support models. The strategies that Rush used to develop C4C appear to be providing meaningful results, with both caregivers and their care recipients having improved outcomes, something that one of our sources said is really exciting, but also makes sense, because if you take better care of yourself, you often have the bandwidth to take better care of someone else, too. And now the program is also growing. Thanks to a grant from the John A. Hartford Foundation, Rush clinicians are offering training and technical assistance to C4C programs launching at new locations across the country. And separately, more than 5,000 healthcare sites have implemented the age-friendly health systems model as well.
Are any of the programs to support caregivers going to be affected by the restructuring or funding changes that we've seen in the government?
There are a variety of potential ways that these changes may impact caregiver support systems going forward. For one, Medicaid offers a way for caregivers of beneficiaries to supplement their income in some states, but there are concerns about the future of that program as the Trump administration's One Big Beautiful Bill Act could reduce Medicaid funding by nearly $700 billion, according to recent estimates from the Congressional Budget Office. Another source also pointed out concerns over the fate of the national strategy to support family caregivers, which she said has been enormously helpful since its initiation. In fact, a 2024 report from the Administration for Community Living, or ACL, found that all of the national strategy's original 350 actions were in progress or already complete, and federal agencies also made nearly 40 new commitments, including the launch of an ACL blog on evidence-based caregiver programs, funding of a national State of the Science on Family Caregiving Research Conference, and the creation of health promotion and disease prevention programs for family caregivers. And even though it does cover all federal health and community service agencies, the work of the strategy was allocated to the ACL, which was established in 2012 under the Department of Health and Human Services, or HHS. But now, recent HHS reorganization has threatened to effectively eliminate the ACL, thus putting the future of the national strategy into question also. And caregivers at Rush are already concerned, with one source who works there saying that the threats to these programs are terrifying for people, especially with so many caregivers facing their own mental health challenges. Still, multiple groups, including AARP and the John A. Hartford Foundation, have reaffirmed their commitment to advocacy for family caregivers, even in the midst of this uncertainty.
Thanks, Virginia. If you'd like to learn more, we'll include links to the stories we discussed in the show description. This past month, Rita also covered highlights from the American Society of Clinical Oncology's annual meeting, which showcased the latest advancements in cancer research and treatment. And we had an interview about an AI tool that may help clinicians distinguish Parkinson's disease from related movement disorders, which stands to improve diagnostic accuracy and patient care. You can find that episode in this show's feed at JAMA Network's YouTube channel or at JAMA.com. Or better yet, follow the JAMA Network podcast, JAMA Plus AI Conversations. That's it for this JAMA Medical News Summary. I'm Kate Schweitzer. Thanks to Rita Rubin and Virginia Hunt. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening and join us again next time.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.